Good afternoon, everyone. Happy October 25th. Welcome to October office hours. I just want to confirm folks can hear me. If someone could just say, hey, yes, I can.
Yes.
Thank
Yeah,
you.
sure can.
Appreciate it. Thank you. So we are meeting for October office hours. I have this recording, so that'll be available on our HI Health Home Training's webpage. So folks are going to be able to access it in the near future from that. And as always, if you have questions along the way, feel free to unmute and ask, or we have the chat function for folks. But today we'll get hopping into it here. So we're going to go over a number of policy and procedures today, program updates in relation to that, and we're going to talk about children's program updates, some NetSmart updates, and then Data Den. So that's going to take up our time today. And we'll jump right into policy. So there's 8 policies that we're going to be going through that came through since our last office hours. So we're going to take some time and touch on each of those. So it'll be the activities and billing protocols for newly referred members in an excluded setting, the adult plan of care, the Kansas, New York assessment policy, children's plan of care, the CS transfer policy, the EMOD, VMOD, AT policy, HCBS rights and choice policy, and systems access policy. And before we start getting into each one, I just wanted to note again that these are all available on our policy and procedures webpage through the HI Health Home website. So folks can access them at any point. So we'll jump right in. And I'll take this one, Jessica, and we'll go back and forth between Jessica and I. But this our billing protocol for newly referred members. There was no real changes on this one. It was just an annual revision to update to make sure that everything was current. And I just wanted to pop this one up just in the event that anybody had any questions pertaining to the specific policy and procedure. It was sent out a couple of weeks back now to the network to be shared with all respective teams. And it is on our website as well for the policy and procedure page. Anybody have any questions around this particular policy? All right, then we'll move on to the next one. So this one's going to be the plan of care for adult health home. Number of changes in this one. It's really looking at clarification. A lot of these came out of our redesignation visit in the spring. And we just wanted to make sure we got some of those recommendations added into the policy as we move forward. And one of those was the first bullet that you see, that to clarify that the health and care manager is the single point of contact in the care coordination and takes full responsibility for the overall management of the health home plan of care. So really that the care manager is the pivotal point for the plan of care and is working with the member to ensure that that plan is what that member would like it to be. So that was something that we needed to clarify. So that is now in policy. Update the policy as needs change. So we shouldn't just wait till, once that initial plan of care is done until the annual is due. If there's any goals that have changed or been discontinued or achieved, that should really be an amendment to the plan of care, and there should be updates along the way. So again, that was something that we didn't have necessarily clarified in the policy, that we wanted to make sure that we just got the verbiage a little clearer in there. And then signing, it's got to be signed and on file with the member. I know we had the verbal in place throughout the pandemic. But the regulatory policy requires a signed signature on file. And we really want to make sure that folks are working towards that and get that on there. And we do audit that when we do our health home audits for each of the care management agencies. And we do look to see for a signed document that says that the plan of care has been signed. So that could be e-signature or wet ink signature. But we have to have that signature on file. And then the collaboration with an MCO is applicable to help coordinate and account for the person's care. So if that person has an MCO that they're working with and that person has health and care management, we should really be striving to communicate with the MCO as appropriate and work towards, getting that person the services they need as they're with us with Health Home. And any requests for the plan of care, just wanted to clarify in there as well. This was a recommendation that the member and or their care team can request any plan of care, as far as copies, any discussion around the plan of care itself. So just want to make sure that does open to folks who have consent as part of the team that can be applicable to the plan of care can make requests for that. And then health home service providers that don't annually update the plan of care, they can be subject to billing implications. I know we've talked about this through the recent months. It was something that came out through redesignation, just looking at quality management program. One of the things we're looking at through quality notebooks as we send them out month to month is that whole plan of care. Is the initial completed in a timely fashion? Are comprehensive assessments completed within the 60-day requirement? Are they annually thereafter updated? The initial plans of care are tied to MAP now. That happened a year ago, just about now, where that's tied to MAP. So that does have billing implication potential if those are not in place and properly loaded into the care manager record. Those are the major highlights for this update for the plan of care for adults. I didn't know if anybody had questions around this particular policy. Comments, thoughts around it? Okay, we'll move on to the next one then. Jessica, I think we're on you now.
Okay, can you hear me?
Yes.
Yay. All right, I'm on my new computer, so hopefully WebEx likes this one. Very exciting. So this is our updated CANS assessment policy. And the most exciting update is that the CANS assessment is now yearly. So we don't have to do a reassessment at every 6 months. You just need to complete that every year, and it will set the acuity and billing rate for the whole year. Taylor is applauding. I know every children's care manager out there is equally excited. Still needs to be completed within the first 30 to 60 days. If it's not completed for the first month or two, you can still bill at that low rate. But if it isn't completed by the end of the third month, you won't get any reimbursement. So that is still remaining the same. The other thing that has come up through some reports that the state has been pulling a couple months ago, and then most recently through some interviews that they've been doing with the care managers, is that they want to ensure that the primary care manager is the one completing these assessments and signing and finalizing them. I've spoke to everyone in our network, and we've kind of figured out what everyone's procedure is for getting these completed. And there's just one outstanding question that I do have with the state for one of our CMAs. Everyone is doing everything great with their CANS assessments. Just continue to do what you're doing, except for that one CMA where I'm just running the process by the state with them. Does anyone have any questions on the updated CANS assessment policy? All right. Children's plan of care. So this was updated to coincide with the updated CANS assessment policy. So now this is also a 1-year amendment. So previously you do your 6-month CANS amendment, and then you do a plan of care amendment every 6 months. Now they are both 1 year. It needs to still be completed within the first 60 days of enrollment. If you don't, you won't be able to bill. So that's same policy as before. It's just now an annual amendment. And then the third bullet on here came from our redesignation, and they pointed out that in our policy, they really wanted us to clarify that the objectives and interventions in our plan of care should relate back to the members' desire to address their health home qualifying diagnosis. So as we all know, we enter our problems into NetSmart, and then those problems are then tied into our plan of care. And then in our plan of care rebuilds are objectives and interventions around those problems. So we should always make sure that when we are building objectives and interventions in the plan of care, they are tied to the primary problem. And those are built in the plan of care by the category you select. So when you enter a problem, you have to enter the category that that problem falls under. So if their primary problem is a behavioral health problem, you want to make sure that in the plan of care, there are objectives and interventions under behavioral health. And this was just something they wanted to see clarified in policy, so that has been updated. Does anyone have any questions on, oh, there's more to this. Apparently they had a lot of suggestions. So the other thing is that they wanted to make sure we have SMART goals, or objectives and interventions are all SMART. So they're all specific, measurable, attainable, realistic, and timely. I believe that's a desk guide in this policy. Strengths and needs are derived from the CANs and the comprehensive assessment. So at the top of your plan of care, you're going to see your strengths and needs sections. Those sections should be reflective of the CANs and the comprehensive assessment. So when an auditor is looking at your plan of care, they should be able to read the CANs assessment and your comp assessment. From there, see those strengths and needs reflected in your plan of care. And then for our youth that are 14 and older, the plan of care has to have a goal related to the member's ability to live independently. Now, this doesn't mean that a 14-year-old needs a goal in there surrounding housing. It could be as simple as a 14-year-old is addressing money management, or they have a cell phone and it's just proper cell phone usage. It's basically going to be the last sections of your CANS assessment would be pulled into the plan of care for our youth 14 and older. And then for our youth 16 and older, it's going to contain goals related to transitioning to adult services. So as our kids approach 16, are they need to be linked to OPWDD? Is that in process? Are they looking at adult health home when they reach 18, or are they going to stay enrolled in children's health home? And then again, those last two sections of the CANS assessment would also feed your plan of care for this section for our youth that are 16 and older. I'm afraid to say
Just,
that's it. Yeah, go ahead.
it's just Lori. I mean, at 16, do we think that that's a good time frame to be talking about transitioning to adult services with kids at 16? I mean, they can do a lot of work between 16 and 18 that wouldn't then precipitate their need to, unless adult services is just, obtaining their own primary care physician. But if we're talking about adult services in terms of,
So
adult
I
care.
I agree with you 100%, and per policy that's what it states verbatim. So I believe that if you had a youth that was that age and it was just simply, transitioning from a pediatric care to an adult PCP, that would be acceptable and fine.
Okay,
But yes, I agree with you.
thanks. I love it when
Sure.
you agree with me, Jessica.
I know. I tend to agree with a lot of you. So the other thing that we had to point out was interdisciplinary team meetings. These were something that had to be conducted every 6 months, but now it's annual with the annual plan of care. The thing with interdisciplinary team meetings, and I know that I've spoken to a number of you about this, is I know that we're doing this. We're meeting with the families, we're meeting with providers. That's what a care manager note is that you're addressing the plan of care. When you talk to providers, the family about the development of the plan of care, when you amend a plan of care, when they give feedback on a plan of care, that's all an interdisciplinary team meeting. Where we're struggling, I believe, and where we're losing fidelity with our audits when it comes to when the state is auditing is they're not seeing the term interdisciplinary team meeting in the record. So I would just say when you document your meetings, if you document them as team meetings or interdisciplinary team meetings, I think that that would be a key word or words that the state could pull out in order to say, yes, we're actually meeting, we're meeting the mark there. Because when we audit the records, I see it. It's just a matter of, I think the state, as they go through our notes, they're not seeing those terms to kind of pull it out and being like, oh, okay, they are meeting this requirement. I think it's just a matter of semantics, and we are not getting credit for the work that we're doing. So I have just, as I've met individually with CMAs and with care managers, just asked them to just literally use that wording, and then that would guarantee that you guys are getting credit for the work that you're doing. And then member signature or consenter signature, just like on the adult plan of care, we have to make sure that we are having our plan of cares signed, whether it be electronically or wet ink signature. And then just a little reminder in here about safety and emergency planning. We now have the one streamlined assessment in NetSmart. It's under additional forms. This safety and crisis plan, emergency plan needs to be done within the first 60 days, just like before. Now it only needs to be updated annually unless there is a safety or crisis concern. If that happens, the plan should be reviewed. In a note, it should be referenced that it was reviewed and then updated as needed. They are during our audits. This was for our HCBS audit and for our redesignation audit. As they reviewed records, they would see hospitalizations and crises occurring. And what they weren't seeing is that the care manager was discussing the crisis plan on file or safety plan on file and or updating it. So just a reminder to at least, reference it and note it or update it if it truly does need to be updated. Does anyone have any questions on plan of care? Okay. Our CS transfer policy. So this one was a annual update, and then there was also just a couple of minor updates based off of HCBS audits. So there's a couple of ways that youth can get transferred to us from CS, and then we can also transfer to CS. So you can make a referral to CS for a youth that does not have Medicaid and you would like to get them Medicaid in order to access health home care management and HCBS services. You would just complete that CS referral form. It's pretty simple. Or you can also refer a member and transfer a case to CS if they no longer want health home services but are enrolled in HCBS. So if they're enrolled in health home, they're receiving health home care management and HCBS services, and they no longer want health home, but they want to continue with HCBS, you would refer back to CS. You can go to the next slide. So the wildest transfer of them all, as you all know, is the CS referral to health home. So whether you complete that referral to CS because they don't have Medicaid and you want them to, and then they're referring back to you, or if it's just a member that is identified in the community, they don't have Medicaid and they want to go through the CS process and then get referred to health home. So once they receive that level of care, they will get Medicaid and then they come to us and then they will transfer that case then to health home. It's extremely important when you accept a referral from CS that it comes through the health home. We have had instances where referrals have been able to bypass the health home. And once that happens, it's too late for me to verify that you have all of the required documentation. And once you accept that referral and get that kid enrolled, you're then responsible for everything that goes along with that kid's referral. And then you're responsible for all of that required documentation. So you want to make sure anytime you receive a referral from CS that you are making sure it came through the health home, that you have all the required documentation, that you checked the K codes. Typically, Courtney was the one that had been reaching out. And then recently we decided, because we were having so much back and forth with CS and there was a lot of issues with documentation and K codes, that all of these referrals, I think, are just going to flow through me. So if you do hear from me about a referral, it means that I have checked it, I verified everything, I've looked at the K codes. If something is missing, then it's not, I'll still refer out, but I'm still following up on the back end to get that missing documentation. And then you'll also see me in the record noting that. So if you see me documenting in your charts, writing notes, it's just because I want it to be clear what I'm doing on the back end, following up on that paperwork so you guys don't have to, and then it's documented for when we are audited. You can go to the next slide. Does anyone have any questions on the CS policy?
Is there a way, Jessica? I'm wondering, I'm thinking that possibly what may have happened previously is if we had a child that came in through SPOE and maybe they were also working on the CS process somewhere else. I mean, I'm not sure if that's what happened with one of the ones that we had. Is there a way that we should be looking at that to shore that up?
So that definitely could happen, because that happened with, I don't know, there was a case at another CMA that somehow got referred to a completely different other health home, which has happened more than once. Because anyone can refer to CS, and there's no way for me to track any of that. There's the only thing that we've come up with is, I know Glens Falls Hospital now has started, anytime they send in a CS referral, they send me the name, so I can just kind of hold that name and have it on my radar. So I know that I'm expecting a health home referral for so-and-so. That's the only thing that we've been able to come up with, but that's not guaranteeing that eventually that other youth will come back through and be re-referred to us. It's happened multiple times where these nurse evaluators and the people from CS are in communication with these, non-med health home care managers, and that are working with them, and then they turn around and then they refer out to a completely different health home. So there's really, at this point, there's no way to track that. Other than if you submit one and you want to give me a heads up, I can at least wait for it to come in and see if it comes in through us. Okay, so our EMOD, VMOD, and AT policy, there were really one very minor update to this based on HCBS audit feedback. It's one of our HCBS services is EMOD, VMOD, and AT. The only recommendation that we had from our HCBS audit was to make sure that the care manager has on file medical necessity. I think where in the one MEDF chart that was audited, I think what happened is we didn't have medical necessity on file. And the problem is that they literally have a form for everything except for medical necessity. So this can literally be a physician's order or a letter written by a physician explaining the clinical need for how one of these modifications would assist a member in obtaining their goals. So it is the responsibility of the care manager to get that, obtain that, have it on file. and then move forward with the process. Then once you have that and you have the identified need, then you have 7 business days to update the plan of care and then notify the Department of Health that you plan to move forward with one of these modifications. Next slide, Travis. So you're going to send that email notification to that email at the Department of Health with that information. Then you can go ahead and move forward with the rest of the policy. All of the steps for the policy are all the steps to obtain one of these modifications are outlined in the policy. What I would recommend is that prior to you updating the member's plan of care that you want to look at this policy. I'm not going to go through all of the steps because it is quite complicated, but there are some strict timelines that surround these steps. So I would recommend that if you have an identified need for one of these modifications, that you move forward with getting the medical necessity documentation, look at the policy, then put it in the member's plan of care to make sure that you're adhering to all of those strict timelines. Next slide. Did anyone have any questions on EMOD, VMOD, or AT? Okay. Next policy is our HCBS rights and choice policy. This was updated due to our HCBS audit that we had. This policy pertains only to youth receiving HCBS services. It goes through their rights and choice to choose a provider, how to file a complaint, report abuse, request a conference, or request a fair hearing. Each participant has to sign that freedom of choice form that needs to be completed after the initial level of care, but before you make a referral for HCBS. And then you have to fill out this form annually thereafter. To accompany this freedom of choice form, there is also the rights and responsibilities flyer. That flyer is in the HCBS toolkit and needs to be distributed to the family and reviewed with them and documented. So in the policy, I've updated the policy to include that flyer is initialed by the family to show that they have had that flyer reviewed with them, and then you would upload that into the record, or you can document in the record in a note that you have reviewed the freedom of choice form, that the family has signed it, and that you reviewed the children's rights and responsibilities flyer with the family. We have the documentation in the record, so everything is uploaded into NetSmart, but where we are not getting credit is in the notes documentation that we reviewed it with them and that we discussed it with the family. Next, does anyone have any questions on the freedom of choice form?
Geez, Jessica, it's not like there wasn't a lot of HCBS audits or, redesignation feedback for children's or anything, right?
No, I haven't been busy at all.
Well, thank you for going through all of that. We know that's a lot, but we wanted to take the time to touch on highlights on all those changes and updates. The last policy I wanted to touch on was our systems access policy. And ultimately, it's just a review, so there wasn't really any change, but we did put an updated form. So the actual form is one of the appendices at the back of the policy. I think it's on page 6. So we're just asking folks to make sure they're using the most current form. We also have it on our HI forms page for the health home for people to access. And we're really asking anytime you have an ad change user for your organization for health home that you complete one of these forms, because we do have to, through our systems and securities protocol requirement through New York State Department of Health, maintain a user, an active or inactive user list for all users that have touched our network platforms that we work with. So in particular, for NetSmart Care Manager, Millen, and DataDen. We have to track and monitor that, and I have to submit quarterly to the security and privacy team through Department of Health that user list, because they do track and monitor that. So we just want to, ask that you continue to be diligent and putting that stuff forward, and then your registration authority, whomever you have for your organization, to be that entity to validate who the person is in actuality, and ultimately signing off saying that yes, this is in fact that person, when you're submitting the form. At AHI, for our internal care management agency, we use our human resources director as that registration authority figure to sign off, because they are part of the hiring process for all the paperwork processing when a person comes on as an employee. So we felt that it was fitting that that was the entity to do that for our care management organization. But that, again, goes back to your organization, what decision you make in regards to who the registration authority is. Any questions around systems access policy in general, or anything around that anybody might have?
Hey, Travis, this is Bob at Essex County Mental Health. Is this connected with the UAS system?
No, this particular form is the policy is tied more to, like, when you got someone coming in and they need access to care manager for NetSmart. If you're a new care management agency and there's a milling account access, DataDen, which I'll be speaking about a little bit further in today's discussion. So for those three systems that we utilize through the health home, that's what this is in reference to. UAS, that's going to be your coordinator through your organization that's linked through the Department of Health. So when the CMA becomes a downstream provider in our network, they have a coordinator established to access that platform and grant access for your employees. So I would defer to whomever that person is at your organization to get that access for your employees. And they also have a help desk number. I don't have that off the top of my head, but there is a help desk number to assist, to help support folks with questions.
Okay, the form doesn't look terribly familiar. I don't, but I can check. That's in what, page 6 of the policy?
Yes, yep. So this policy we put in place back in July of 21. So it's been a year and a few months now since we initially implemented it throughout the network. And this came from that system security protocol initiative that we had to work through for the health home. Each health home in New York State has to push through that process, and it's really to show that you're protecting all of your PII data and access to those data platforms. And AHI went through that process last year, and part of doing that, we implemented this systems access identity assurance policy to the network. So that's where this initiated from. As we move forward, we're going to continue to update and accordingly as things come forward.
Okay, thanks.
Yeah. Any other questions around this or any other policies? I know we went through 8. That's quite a bit. But we wanted to pause, for a little bit before we move forward on the rest of today's discussion, just in case anybody had anything to come up along the way that you didn't get a chance to ask when we were hitting on some of the other policies. Okay, we know where we're at. If you have questions, feel free to reach out and we'll get back to you and help you out. All right, Jessica, you had another slide.
Yes, I'm back. Just a couple quick updates and reminders. I just want to thank everyone who participated in the interviews with the CANS Institute. Some of our CMAs and care managers were randomly selected to do that. Just thank you for your patience with all of that. I know it did not go smoothly as far as scheduling with them. So thank you. Other reminders, we just went over policy, but the cans and plan of care for children are now yearly. And then a quick reminder that all non-self-consenting members just need to have that updated 5201 on file. Did anyone have any questions on any of that?
All right, thank you, Jessica. That's smart. I don't know if folks recall, we were talking in this past spring, I want to say it was probably around March. NetSmart was working on a new self-report platform, and they were going to be implementing that in to NetSmart. And then that was a hurry up and wait. And we were just recently notified, actually last week, that they are now ready to move forward with that new platform being implemented into production. And we're being told it's supposed to happen as of November 1st, and that they will have the old self-service reports that organizations have developed in the system for the month of November and December. As of January, that old reporting platform will be no longer activated or accessible. The original timeline we were given shortened up somewhat. So I'm cognizant of that, and I apologize for that. I know some organizations in the network use this report function quite frequently. All I can say at this point is if you have certain reports that you really are concerned about losing or not sure how to save or create, to reach out to Taylor Dawson, and we will work with you to do what we can to try to get those maintained, or work with NetSmart if possible. One thing they did say to us is they're not going to be able to take all reports that have been made out there and carry them over into the new platform. So I would just really encourage folks at organizations who do use this function to go, get that to your supervisor so that we can, work with you. Taylor, was there anything I was missing in regards to that outside of the very short timeline that we were given that we're expressing to the network?
No, Travis, can you hear me?
Yes.
Okay, perfect. No, I think you covered everything. They were just definitely encouraging folks to try to recreate the reports on their own while you do have access to both systems for November and December. And if you do come into any problems along the way, definitely reach out and they will assist as they can.
Yeah. Thanks, Taylor. And also we're doing a lot more of a report building on our end, as well as we try to make our quality for the program, for the Health Home Network, more robust, to support you all in the work that you do. So, if we can do anything that's not able to be remedied through the NetSmart's current platform, we're more than willing and happy to do what we can to try and develop something through the Health Home. So we just want to make sure that we're extending that as well. Is there any questions or thoughts? I'm sure there's some grumbles out there, because when we heard it last week, we were like, this is a short window. We were told originally it was going to be a few months, not a month and a half ultimately, because you have the holidays factoring in. So it is very short, and I do apologize for that. Okay, I'll move forward then. Let us know, though. Please reach out. We're more than willing and happy to assist. Another thing that we were notified just recently too is there's a new service ticket request team that's been assigned to our Health Home to assist with network issues relevant to the Care Manager platform. So I wanted to make sure everybody knew that. So if you are running into any bumps in the road, more than usual concerns, please let us know. Because one of the things, even though they're a new team, I think it's only fair and appropriate to give honest feedback if we are running into issues and concerns. So we want to be aware of those things if there are. And if there's great response, we want to hear that too, because we want to be able to give that news as well. But that just happened within the last couple of weeks. And, so please let us know how it goes if you're reaching out and in your interactions.
Hi, Travis. This is Tina. I just
Hi, Tina.
to touch on that, as far as NetSmart goes and service tickets, do we have any clarity or know where things stand as far as the comp assessment and the issues with saving and completing certain portions of the comp assessment?
Yeah, actually, we've been working with NetSmart on that. Taylor, do you mind giving the most recent update that we got?
Sure. Yes, we do apologize for that. I know there's been a lot of issues with the comprehensive assessment. They have pushed some updates into our UAT environment. And a couple of the issues have been resolved, but we are still working with them on a couple of the other issues that are occurring with the comp. So we appreciate your patience with those. We do hope to have it working appropriately very shortly.
Okay. And as long as we document that we are attempting to complete the comp assessment, if that's the only thing holding us up as far as billing, we're cool to bill, right?
Absolutely.
Great.
Yeah.
Thank you.
Yeah, you're hitting right on, Tina. Just
Yeah.
document your efforts, the date, what the issue, that there was an issue with, the comp not saving, the system kicked me out. I would just write the story. I mean, you don't have to do a novel, but make sure you get it in there so that if there ever was a question through an audit, it'd be clear that there was an issue with the platform, not the person that's, assigned to the case.
And the other outstanding one, I've had a number of clients. We haven't gotten Hixney notices on as far as ER visits, and I know I've reached out. I never hear back, so I was just kind of curious if other agencies are having that periodically where we're not getting Hixney alerts.
Are we getting that feedback from other organizations?
Hi, Tina. This is Mary Baker with BHSM. Yes, we're having the same problem where we don't consistently get the alerts.
Okay. Thank you, Mary. Any other organizations not getting alerts consistently?
This is Heather from HCR Care Management, and I don't ever get any notifications from Hixney.
Okay.
Catholic Charities, we get very few, but we also have our own connection to Hixney. So we get a lot of our alerts through a separate system, but it's fleeting through the EMR.
Okay, that's good to know. We can put a ticket in regards to that. I wanted to mention, because this has come up from time to time. Now the Hixney, the HI Hixney form has to be completed in enrollment so that those alerts can come through for a member. Now, obviously, I'm hearing that there's an issue with that currently from some organizations, so we'll look into that. But that form is only specific to ER hospital admission alerts. It's not going to give access to the Hixney portal for other data. So, Heather, you touched on something that I just wanted to make sure our CMAs are aware of. AHI Health Home does not have Hixney portal access, nor can we grant it to our care management agencies in the network. So that's not something that we have in place or that we have access to. So if you have, through your own organization, an agreement with Hixney, I would go through your security officer for Hixney through your organization, and that would get you access to members that are tied to your organization for the Hixney data. So all the the Hixney HI form for our NetSmart Care Manager, that's just going to prompt admission and ER alerts, hospitalization alerts. And it's not going to give you anything further than that. So I didn't know if folks really knew what that intent was with that form, what was the backdrop to it, but it's not going to get you access to the Hixney portal, and it's not something that we manage.
Travis, this is Taylor. I just have one comment that I want to insert on a couple of the Hixney issues we've had in the past. I will say that for kind of one-off Hixney issues, we, in communication with them, they don't use SIN number to look up or cross-reference the members. They look at demographic info, like address and phone number. So if character gets typed in wrong or something is incorrect in the member giving those demographic information when they're admitted to the ER, that can cause the HCBS alert to not come through NetSmart.
Thanks, Taylor. I see some comments in the chat too that I'm just reading now. When I was talking, I was kind of staring at the wall so I could keep my train of thought. But I see Michelle, I see your comment that you're not getting the alerts also through Fort Hudson. Jessica, thank you. You're seeing a lot of duplications though. So we can make sure we bring that forward. Kristen, okay, you don't utilize the HCBS alerts. Okay, so you have access through HCBS portal through Alliance. Got it. All right. And White House, Tanya, you've had some access issues for alerts as well. All right. And then Michelle, I see you commented that the not always matching the actual HCBS portal, and then the NetSmart HCBS alerts aren't also always matching. All right. So that's feedback we can bring back for sure.
This is Taylor again. Hi.
Yes, thank you, Taylor.
I am just thinking it would probably be easiest for us to set up a call with them because it seems like a lot of agencies are having issues. So if those that are having issues could send me one or two alerts that you have missed in there, they haven't come through with the member's name, the date of the admission, and if you know where they were admitted, I can compile that and have that ready to go when we're able to get a call scheduled with them.
Yes, thank you, Taylor, because that's one of the things they will ask. Well, can you provide us with the actual, issue, so that they can look into it?
This is Lori. I've had several where I'll get an ER alert and they're actually admitted into the hospital or on a unit or a different facility, and the hospitalization alerts aren't coming up. So I have several people that I had to go in and create my own Hallmark events for because of
Okay.
that.
Yeah, we've had issues in the past where sometimes when they go in for the ER visit and then they get admitted, only one of the alerts is coming through and so on and so forth. So feel free to send those over as well, Lori.
Yeah, and we apologize that this information hasn't been coming through fluidly and accurate. We'll definitely have a meeting with them and bring those forward and see if we can get this remedied so that it's not such an issue for folks. It's hard enough to get our jobs done as it is, and then we run into this stuff, right? The frustrations start to compound then. So thank you for the feedback, everyone. Does anybody have anything else around HCBS or alerts? Okay. Data Den. So I know, gosh, I want to say it was not this past summer, but the one prior. Ann Hutchinson had some folks from Canon Company do an overview of the Power BI platform for the network. And it was kind of like what the heck's going on? There was a lot of information about the ability of this platform and whatnot. So then we put a pause on it because we were trying to work out a way to make it user friendly for our network. And so that's what we've been working on over the last year, is working with this Canton Company and another organization called ProArc to work on this Power BI platform, which is the name of the platform. And it's basically compiling all different data from NetSmart, data from Psyches, data from some other platforms that we work with, and funnel it to like visual reports for folks so that it's more real-time data, if you will, and it's in a visual mode so that people can see it and it's user-friendly. So we've done a soft rollout. I know we mentioned it earlier this year. It was something that we wanted to try and roll out by the end of 2022. So we've spent a lot of time over this past spring and summer and into this fall working with those two organizations I had mentioned to get it ready to go. And we're at that point now. So this is not something that's going to be a cost to our downstream providers. It's a cost that AHI has incurred through our health home. We're the administrators of the platform. We do everything on the back end as far as building the reports and the data that funnels into it and whatnot. This would be a read-only platform that you can access as a supervisor and for all the care managers once your organization is brought onto this platform to look at your upcoming care plans, your upcoming comp assessments. How many days are they overdue? How many days before they become due? Where are you at with folks in diligent search? How many notes do you have in draft on your caseload? It'll give a snapshot of how many notes are in draft on all caseloads for the supervisor to see. It'll give you, what your year to date, if you were a supervisor, revenue is for your CMA. It'll give you, different trends as far as your net enrollment versus discharge as an organization for your supervisors to be able to see and access. So it's dependent on the level that you have to have access in the system. You'll see certain reports. So we're excited about it. It's a quality management tool that, may be a little reactive initially when people first see it, but then once you get into it, you start looking at it, it becomes a proactive thing because it gives you snapshots in time that are going to be manageable versus, having 7 or 8 different spreadsheets that you're trying to sift through on a monthly basis to keep track of everything that's going on. So what we're going to do over the month of November and December is we're going to be reaching out to all the organizations. We're planning on doing 3 a week, ultimately, if everything jives. Myself, Taylor, and then Amber Baker, who came on with us about 4 months ago. She works with the AHI, with the health home, and also with our Adirondacks ACO. She's a support specialist for us, and she's going to be the technical expert, if you will, for the data den on the back end and help to build reports. And the 3 of us are going to be doing basically an introduction to the platform for each of the CMAs and walk you through it and answer any questions you have, et cetera, and get you live, basically, and to be able to start using it as a tool for you in your work. So what's going on right now is we're pulling together that email that's going to send out that invite to get the meeting set up. That'll be coming out in the very near future because, again, we're looking at November and December to do the rollout. With that email is going to be a spreadsheet for supervisors to validate their staff, because we're looking to have all care managers at your organization to have access, and the supervisors, so they would validate staff and then who they want to have supervisory access versus not supervisory access. And then what will happen is Taylor and Amber will work to get people access to the platform. So when we do meet with you, you'll be ready to go and can get in there and start playing around. You're not going to hurt it because it's going to be read only. So it's not like you're entering data or manipulating data. That's already done when you log in and you're looking at it. So you'll see as we do that rollout. The one thing that I wanted to mention with it as well is that, we're really excited about this becoming something that you use routinely, and it will eventually take the place of a lot of the reports that Taylor sends out on a monthly basis to all the supervisors, because you're going to be able to pull most of them out of the data den, and you can pull them readily at any point along the way. So I'm excited about that. So it's going to be really a real tangible product that people can use and see. You don't have to, like I said, you can't manipulate or enter data. You don't have to type notes, nothing like that in there. It's purely a resource for folks to better do their work with. Trying to think what else I wanted to mention about it. Taylor, did I miss anything on the big highlights? We're thinking about an hour when we meet with each of your organizations. It may not take that long, but we just want to.
I don't think it'll take that long, but it'll give folks an opportunity for any Q&A. And if there are any login issues with getting the account set up, we can help during that hour as well.
Yeah.
And then, of course, as you guys, we'll explain the different reports, where the data comes from, and most everything refreshes nightly. There's a couple things that pull weekly, so we'll go over all that so you guys have an idea of how up to date everything is. And then of course, we're always looking to build new things in there. So it'll be really nice for everybody to get their hands on it and let us know what additional reports would be helpful.
Yeah, and this tool could take the place of maybe some of those reports that you may be using in NetSmart that you're creating through the self-reporting server. If that can't happen moving forward, or if there's an issue somehow with that, we may be able to look at that through data then potentially. So that, like I had mentioned earlier, we're more than willing to work with and talk through those types of things. I did want to mention too, we're going to start with those organizations that have done the soft rollout with us. Their supervisors with those organizations have had access at this point, not their care management staff. So we thought it'd be best to start with those folks because they've already got supervisors in there. They've had a little bit of time with it, and we can go to that next step of going through it with the care management team as a whole. So for those of you that have had a soft rollout, you'll be the first group that we're going to be reaching out to start this rollout network wide. So that's the 50,000 foot for data den. Any questions, thoughts? I mean, clearly when you see it, it'll make more sense. We hope it's user friendly for folks. We're excited about it. I can feel the excitement right through the PowerPoint. It's awesome. All right.
It's very exciting. I think everyone's going to love it.
More to come on it, but it's coming. Finally, we've been working on it for a while, but it's finally here. So, all right. So stay tuned. We'll be in touch on it. Thank you, Karen. Appreciate the applause. And that's it for today. A lot of information shared, especially around policy and procedure. But I didn't know if folks had questions or anything else they wanted to talk about today. I think I mentioned last time, Shelters of Saratoga is our newest organization in the hopper. So they're in there with St. Joseph's Rehabilitation Center and People USA for the next 3 organizations that will be onboarding into our network through Health Home. And we have another one that we're starting discussions with as well that's looking at Saratoga County. So, as a lead, we're going to continue to grow. It's one of the things strategically that I'm looking to do for our network. We have some areas in our region that there's a lot of need, and having more provider availability will help support some of those referrals that are out there that are continuing to be out there and not being able to be met. So we're excited about those folks coming on and adding to our already awesome team of providers in our network. And a big thank you, as always, for everything you all do. We really appreciate it. So next month is our last scheduled office hours for this year. I don't think we had one for December, given the holiday season. But if there's some reason that we need to do a special meeting, we definitely will. But otherwise, we're pushing toward the end of the year here. Crazy. Oh, Rick had a question. I was just looking at the chat again. No, it doesn't just pull from data from NetSmart only. Taylor, you pop off. I know we pulled from Psyches. Where else are we pulling?
I'm here. Sorry, I didn't see that question either, Rick. So the data gets pulled. A lot of it does come from NetSmart, but we also pull from MAP and then some other sources, but mostly MAP and NetSmart.
See if we missed any other chats here. I think that was it. Jessica Casey, thanks for vouching for data, Den. Appreciate it. All right. Well, with that, thank you, everybody. I hope you have a great afternoon, and we'll talk soon. Take care.
Take care, everybody. Thank you.